Good evening and welcome to Money Matters. My name is Kimon Hatza and I'm a business attorney in Radnor, Pennsylvania. I focus my practice in the areas of life sciences, healthcare, and information technology. Tonight we're continuing our special series on life sciences, healthcare, and technology leaders in the Philadelphia region. Before I get started, I do want to remind our viewers that from time to time financial issues relating to life sciences, healthcare, or technology companies or matters may be discussed on the show. These discussions are not and should not be viewed as financial advice. Moreover, since this program is pre-recorded and shown at a later date, please keep in mind that the information may no longer be current. You should always check with your financial advisor before entering into any financial transaction. I'm pleased to have with me as my co-host this evening Charlie Huntington. Charlie is a co-founder and board member of BioStrategy Partners, a tax-exempt organization that helps life sciences entrepreneurs grow and build their pre-seed companies. Charlie, welcome to the show. Thanks for co-hosting. Well, we have an ambitious schedule tonight and a terrific guest, and I know we often kick around some hot topics in life sciences at this part of the show, but because there's so much to cover, I thought it might make sense for us just to jump right into our show this evening, if that's okay with you.
Sounds great.
Okay. Before I introduce our special guest this evening, I do want to remind our viewers that if you have a question for us that you would like us to answer on a future show, please feel free to send your questions to Money Matters TV, 205 East Levering Mill Road in Ballackinwood, Pennsylvania, or alternatively, email your questions to moneymatterstv@gmail.com. It's now with great pleasure that I introduce our special guest this evening, Dr. Russell Maulitz. Dr. Maulitz is a physician who's been practicing internal medicine in the Philadelphia region for more than 30 years. He's also a founding partner and the chief medical officer of Starship Health Technologies. Starship is a research and development firm in the healthcare information technology space. Dr. Maulitz has previously served as managing medical information scientist for CHI Systems. At CHI, he worked closely with Starship CEO Wayne Zachary in research and product development for mobile health and clinical communications training. He's a professor of family medicine at Drexel University College of Medicine. He's also served previously as a faculty member at several University of Pennsylvania affiliated departments and hospitals. His current department operates the first patient-centered medical home opened by Drexel Med, a topic that we're hoping to cover later on in the show. Dr. Maulitz has been the chief of Drexel's Division of Medical Informatics since 1995. He's also authored books and published numerous articles in the field of medical informatics. He earned his undergraduate degree from Harvard University and his MD and PhD in History of Medicine from Duke University. Russ, welcome to the show.
Thanks, Kimon. Nice to be here.
We're happy to have you. I was wondering if you could tell our viewers, or define for our viewers, medical informatics and healthcare information technology.
Sure, I'll try to do that. You might look at medical informatics as the science of healthcare IT, and the healthcare IT or health IT, which I view as somewhat interchangeable, as the technology. So an informaticist is going to do the information science, and informatics really is where computer science and healthcare and information science, as it's done in a lot of schools of information, come together and where they overlap. So informatics is the science, health IT is the technology, including getting down into the weeds of rolling out electronic health records and all of the standard sort of technological realities of the modern world.
Mm-hmm. Now, how did you first get interested in this area and get involved in it?
Well, I guess you could say it happened in a couple of stages. When I first came to Philadelphia, I was really here primarily, although I saw a few patients, but I was primarily here to teach medicine in historical perspective. And what I found was that data management was insuperable without utilizing the new computer technology. And I have to say, it was my graduate students at the University of Pennsylvania who first taught me about how information technology and the use of computers could really help with that. So it really started in the non-clinical arena, and pretty soon the tail started wagging the dog, and pretty soon I started seeing more patients. And as soon as I started seeing patients, it became clear that as I was drinking the technology Kool-Aid, some of it tasted pretty good, and not always though. Sometimes it was a little bit on the bitter side. And so I decided to start brewing the Kool-Aid and not just drinking it. And that's the short answer.
Why are medical informatics and health IT becoming so important right now for the, as the medical practice in the U.S. develops? Why are they becoming so important?
Well, they're important for a number of reasons. Probably the tsunami that's hit, especially since the two big legislative enactments of the last several years, which is the HITECH Act and then more recently Obamacare, the Affordable Care Act, is the advent of the electronic health record. Just in the last very few years, American hospitals have had an 8-fold increase in the adoption of electronic health records, spurred by this legislation. So you can see why this is going to cause the scale of the whole thing has just dramatically increased. It has created a demand for lots and lots of. It's created a lot of new jobs. There's a lot of new jobs in health IT. Where a lot of people have moved over from more general IT, and it's. Despite which, it's still very early days. So that's one of the reasons it's important. Another reason that it's important is because there's a lot more attention to privacy, and so the Healthcare Information Privacy Act, or HIPAA, has become more and more important to people. And all of these represent controversial areas that are still being worked out, and there's still a lot of mileage to go. It's still very early days.
Now you hear a lot about, and you read a lot about the fact that that health IT is going to revolutionize medicine. It's going to make it more efficient. It's going to be more cost effective. It's going to improve patient outcomes, a whole variety of things. Why is that, and how can that be?
Well, I remember the politicians got into this sort of around the time of the 2004 and 2008 elections, and Newt Gingrich once said, paper kills. And the truth is that health IT, ironically, has not done away with paper. And so far, the electronic health record has not clearly been shown, and I hope I'm not stepping on anybody's toes here, to improve clinical outcomes. However, the portents are very good for the future. It's still early days, as I was saying. Would I personally go back to paper? No way. Do I spend less time now because I have computers to do clinical medicine? Also, unfortunately, no way. The electronic health records are still in early days. They sit in silos. They don't talk to each other. There's a huge push now with Obamacare for interoperability and health information exchange, more aspirational at this point than reality.
Can you talk a little bit about aspirationally what you could see happening if the silos go away and things are done properly?
In the business world, there are a lot of. I went down to a month or two ago to the HIMSS, which is the big industry trade show down in Orlando, and there were lots and lots of vendors who were putting out mostly more of the same, what I call the thrice chewed cabbage. But around the edge, and those were the big displays, the big $1 million displays in the middle of the room. But around the edge, we're kind of like at the point where the dinosaurs are still roaming the earth and the asteroid just hit. Around the edge, you've got a lot of people, the little furry mammals, creating these new applications that allow information to be exchanged back and forth. And that's part of why we call our organization, our new startup company, Starship, because we're not trying to build the spaceship. The spaceship is there. We've already been to the moon and back. Now we need to try to figure out how to build a Starship.
You've been practicing medicine for more than 30 years. How has your experience as an internist enhanced your abilities in the medical informatics and health IT space?
Well, not to be flip about it, but certainly the fact that I feel the pain on a daily basis, but ironically the pain of not having adequate data management, and in some cases having data management that doesn't quite yet work the way you want it to, helps me to understand what could be, understand what you might call the possible worlds yet to come. So being a clinician shows me where the pain points are. It certainly gives me credibility in the health IT world. It allows me to, and it also allows me to identify what I would call sweet problems that would be fun to try to solve for small startup companies, and there are quite a few of them now forming as a result of not because of me, but because people are beginning to recognize the sort of interstices between the big chunks of concrete.
Okay.
Russ, can you tell us about the Starship Health Technologies LLC?
Sure. We at Starship, there are three founders, myself, you mentioned Wayne Zachary, Kimon. We have a superb person in the area of training and evaluation and virtual training in our Orlando office, Janice Cannon-Bowers, who has been great fun to work with. Wayne introduced me to her, and the three of us decided to create this startup a year or two ago. And we are so far privately funded. We've had a pretty good early track record with attracting small-scale investment and contracts ranging from the National Institutes of Health to the United States Navy. And we're hoping to expand in the next year or two and become much more visible. I'll give a shout out, starshiphealth.com. Anyone who wants to know more about what we're doing, feel free to have a look.
Excellent. Have you all explored, or are you in the process of developing any new technologies, proprietary technologies?
Yes. Jan and Wayne, and me to a smaller extent, are working on some new ideas around, for example, creating in a computer-based virtual world interactions between patients and doctors to do things like help create awareness among physicians of the cultural context, to train doctors how better to communicate with patients, how to manage their decision making better, and we've had some pretty good luck in that area. We also work in an area that is more my wheelhouse, which is the coordination of healthcare. Because as an internist, I do primarily primary care. I'm not in the hospital very much at all anymore. I used to be a hospitalist, but I really like ambulatory care. And what we find is that there's a niche for technologies that is as yet unmet, or as a need that is as yet unmet, for technologies that allow the outpatient world to talk to the inpatient world, and also for people who are in different organizations to talk to one another. Right now, this notion of interoperability between systems is paid a lot of lip service, but we're not yet there, and we believe we have some ideas that, in terms of new proprietary technologies that can help with that.
Okay. So you just touched on one issue, which, in terms of the current healthcare delivery system, things that you're trying to improve upon at Starship. Are there any others that you'd like to mention?
Those are our two major foci at the present time.
Okay, perfect. How are these issues currently being dealt with in the marketplace?
Interestingly enough, the training and evaluation notion is one that's largely mired back in the 20th century. And what I mean by that is that when medical students and residents are asked to demonstrate that they have capabilities, they sit down face to face with a standardized patient. A lot of that is because so much of healthcare and medicine, and the practice of medicine, is hands-on, or they sit down with simulator dummies. But we believe that and that's very expensive, by the way. Excuse me. Those dummies can cost tens of thousands of dollars, and the simulation labs, we have one at Drexel Med that's been very successful, supported by Independence Blue Cross to the tune of many millions of dollars, house in many cases standardized patients who are real live actors. And interestingly enough, some of those actors are my real patients. So I find myself,
wow.
Kind of being measured up for, am I listening to the heart correctly? But that's an expensive way to do things. And if you stop and think about how a national examination or certification test would be given, people have to travel from all over the country to testing centers so they can put hands on. We believe some of that, at least, especially in the communications arena, can be ported to IT. And on the care, in the matter of care coordination, there are beginning to be some of those small furry mammals emerging that are doing things to help people coordinate care, like better messaging systems, better event notification systems, and a variety of other kinds of applications. But they too are a little bit narrow gauged, and what we're hoping to do is roll them all together and try to provide for better awareness, particularly on the part of providers, of the whole context of the patient.
So who right now really is the quarterback? And what I mean by that, ultimately the doctor is, but what I mean by that is, and I'll just use some names around the Philadelphia area since we're a Philadelphia-based show. You've got Drexel, you've got Penn, you've got Mainline Health, Jefferson, right? You've got Independence, Blue Cross Blue Shield.
Who's driving them?
In other words, are those systems now able to talk? If I'm a patient at one, is Independence, Blue Cross Blue Shield going to make that? And feel free to say that's a bad example and insert some other. I mean, who's got the ball? Who's keeping track of my health records?
Each integrated system, Jefferson, Penn, Drexel, has a database, and the truth is Aetna and IBC also have databases. Do they talk to each other? Up to a point. There is no part of the problem is there is no single quarterback, and data is often siloed. One of the person who should be the quarterback, if you really stop and think about it, is the patient. And one of the things that's been shown just in very recent months, really, to make a big difference is so-called patient portals, which is something that gets tacked on to the electronic health record that allows the patient to view their own record. This is a hugely quickly evolving field, and it's being driven since who pays for the patient portal? I mean, whoever buys it from the electronic health record company, it doesn't come for free.
Right.
But what's driving it is that it's part of the so-called meaningful use criteria for electronic health records. So anybody who wants to amortize the cost of having adopted an electronic health record has to eventually, and that time is actually right now. My practice is rolling it out like tomorrow or next week, have a patient portal that talks to the health record. And I think that's epic, because what that means is the patient really is in the driver's seat, and that's the source of the concept of the patient-centered medical home.
So is the evolution of this stymied by HIPAA, or is the evolution of these systems all talking together stymied by advances in technology?
It's a little of everything. It's also stymied by the fact that the person who's making the buy decision is not necessarily the patient or the physician or the advanced practice nurse.
Okay.
So there's a lot of people, either real people or virtual people, in that exam room. It's not just me and the patient. And a lot of the decisions about what that technology is going to look like are not actually made by me. Nobody asked me what the design should be like. So I'll tell you, the best thing that the electronic health record does in 2014 is provide for adequate proof of billing. And what's happening is that these notes that doctors used to write, which used to be as short as that, are now getting ever longer, because it's kind of like making sausage, and it's sold by the pound, and that's not right. And there's a huge blowback attempt on some people's part to say, keep it short, keep it pithy, and keep it patient-centered, and that's all pretty much yet to come.
Okay.
I was just staying on that point for a second, the portals. And I'm experiencing, I've just got the benefit of that now recently. And one of the things,
your own little episode.
But it was a positive one, because it was a convenience thing from the patient standpoint. I mean, historically, if you had an X-ray or something like that, and then you went to see a physician, at a hospital or a place where the X-ray wasn't located, you had to drive over to the place, get a copy of it, take it with you, and physically, deliver it. If you wanted the report, same thing, you had to wait till it got mailed to you. Now you can go right into the system the same way the doctors do.
Right, exactly
pull it right up and see it. I mean, the convenience of it is really amazing.
And it's more than just convenient. It's also been shown just in literally in the medical literature in 2014 to have some improvement, at least in diabetic patients, in outcomes. And this is all hot off the press. Up until now, a lot of people have, it's almost getting trite to moan about electronic health records not improving outcomes. But now some of these tack-on technologies, such as patient portals, are actually beginning to improve. And it's an interesting question to try to understand why that is. I mean, maybe it's because patients understand their own disease better. I'm not sure.
And maybe they become more active in their own care because they have the ability to do it, through electronic means.
We may hope.
Yeah, I like everything I'm hearing here that we're saying, except turning the patient into his or her own professional, because that's where it gets scary. If you say, all right, Charlie, who may know something about finance, is now in charge of his, put the flag up when these two things shouldn't be happening together within healthcare, I may not be able to know what pothole or what iceberg my ship's headed into.
Of course, that's nothing to do with technology, because
that's true.
Long before the EHR, people used to tap me on the shoulder in the exam room and say, "Hey, you're the doctor," and there's a kind of a push me pull you going on there, and one of the things that portals do is actually to allow for secure messaging back and forth between the doctor and the patient. We're not supposed to be emailing our patients at all right now, and I'm not going to go on network television and pretend to and state how I handle that, except to say that patients are very demanding of access to their doctor because they want you to help them. It should be a collaborative decision-making process, and both people have an important role.
Exactly. Yeah, by day, I'm a financial advisor, and I know 20 years ago, it was you stand at the top of the funnel, and basically you put ideas down the funnel, and the client stood at the bottom saying, "Wow, I've never heard or seen of this before."
Like Audrey too, yeah.
Now we stand at the funnel are the CNBCs, the Bloombergs. They're loading clients up with things where they have a tough time deciphering, should I pay attention to that or not?
Yeah.
And it's almost the same thing you're
Absolutely,
focused on, where you say, ignore the 15 things you just read on the internet, Mr. Schmudlap.
Which, by the way, I spent a lot of time doing.
Exactly. Probably playing whack-a-mole with, the...
that whack-a-mole metaphor is one that I use a lot with my patients because...
we're going to get along fine.
Because a lot of what we're doing nowadays is playing a whack-a-mole. This kind of omnivorous, ever-present data tsunami is a mixed blessing at best.
Absolutely. Thank you.
One of the things we hear from a lot of the guests on our show, particularly those in the pharmaceutical space or medical device space, is that there's been a clear pullback
in pharma
of investors, in large part because somebody comes up with an idea, and then the development of that idea through all the clinical phases and so forth takes a long time, 7 years, 8 years, 10 years. And so particularly, if not private equity, venture capital, just, is not anxious to leap into these things at as early a stage as they had done historically. So a lot of people are saying,
hear that.
You see money pulling back. Yet from my own practice, because I work in this space, I see more and more health IT activity than I do anything else. And I was wondering, from an investment standpoint, are you seeing the pullback in health IT, or is it just the opposite?
It is just the opposite. I think Delaware Valley is kind of a special case because health IT, not unlike, by the way, New York. New York is not that far ahead of us on the health IT side, is still a little bit vestigial. There are lots of efforts being made to overcome that, whereas pharma had a very robust ecosystem of investors and big companies and small companies and inventors. And with the pullback in that area, I think investors are getting a little restless about where can I'm probably, as the clinical guy, I'm probably the least well qualified to answer these investment questions. But I think that the investment is beginning to flow. We're talking to investors ourselves now. And also I think that there are people who largely grew up in that pharma ecosystem who are kind of retooling their own thought process a little bit and thinking about how can they diversify and how can they actually put some dollars into health IT, because they understand that health IT is coming on strong as a result of this huge, rapid influx of technology into hospitals and into outpatient systems and into, to the extent that the politicians allow us to do it, the study of outcomes, which means a research ecosystem around all of that that tells us what works and what doesn't.
And our time is limited, but can you tell our viewers what are patient-centered medical homes?
The patient-centered medical home, I actually wrote out a definition of it from a couple of different organizations because I want to be very precise about it. The PCMH, as it's called, is a model for healthcare that came in just a very few years ago. The state of Pennsylvania has actually been fostering it. It's based on an ongoing personal relationship between the patient, the doctor, and the healthcare team. And the team notion becomes more important than ever as you need to have ways of making sure that a physician or an advanced practice nurse is able to do what they do best and have support people who do some of the things that previously fell to the physician. So it's a care delivery model where patient treatment is coordinated through primary care physicians to ensure they or nurse practitioners in some few cases to make sure you get the care you need when you need it.
Okay. So I'm assuming this is where the puck is going in your mind?
No question. And I recently, in fact, I think I saw you at this meeting of the Philadelphia Health IT Circle, where the chief physician at Independence Blue Cross talked about the fact that in the next year or two, if you don't meet the spec for a patient-centered medical home as a provider, you may no longer get the contract to do insured care
from IBC or Aetna.
For IBC or Aetna, or there may be other inducements, like if you're a patient, you can forego having to come up with a copay if you go to a PCMH.
Okay. Is there, when we talk about the team, are the teams initially, in your estimation, going to be siloed within, let's go back to the three we were talking about, Jefferson, Drexel, Penn, or are there going to be, you can get your wide receiver from the Eagles and you can get your defensive lineman from the Browns? I mean...
Well, that is a fabulous question, because, and I'll give you two different answers. One is that the patient-centered medical home will, within the next few years, start to morph and is already morphing into new organizations called accountable care organizations, or ACOs, where people who may...
We have about 30 seconds. I just wanted to let you know.
The ACOs are going to bring together all these multiple different sources.
To talk together?
Yeah. Okay,
thank you.
I don't know whether you can say it this quickly, but why do you see Drexel as a likely place for innovation in health in this? I
want to give a shout out to my other employer, because I think the new president, John Fry, who's the new president of Drexel, the new senior vice provost Debbie Crawford, and the senior vice president Keith Orist are creating an innovation neighborhood which is pretty unique in the Delaware Valley.
Okay, great. Well, look, we could go on for a lot longer.
That was a quick 22 minutes.
It was very fast. Russ, it was a pleasure having you on the show.
Great being here. Thank you both so much.
Charlie, thank you for co-hosting. I'd like to remind our viewers that on the next show is Lucinda Duncalf of Real Food Works. For some of you who may know Lucinda or recognize that name, she's a serial entrepreneur that's had a couple of successes in the technology world, and now she's changed her focus a little bit, but I've actually heard her speak about this new company, and I'm sure it's going to be a great project for her. Also, for our viewers, for our Philly viewers now, you can now see us on PhillyCam on Comcast 66 and on Fios 29 each Wednesday at 11 a.m. Thanks, everybody, for watching, and we'll see you again next time.